Hello, and thank you for taking the time out of your evening to join us for this fertility preservation webinar on egg freezing with Dr. Agnese Gambaro and Rachel Smith, Embryology Innovation and AI Lead. Following the presentation, they will be responding to your questions. You can submit these at any time during this evening's webinar via the Q&A panel on the right-hand side of your screen. I'll now hand over to Dr. Agnese Gambaro. Please go ahead.
Hello, good evening, and welcome to this presentation. We will be covering, in particular, with in the fertility preservation field, the egg freezing. And so we'll start from the very basic to understand why egg freezing could be useful. First of all, we need to understand what is the egg reserve and in which cases it may be relevant. So if you imagine how the ovaries are made, basically it could be visualized like a big warehouse of eggs. And those eggs are all organized in boxes. Each month, so each ovarian cycle, what happens is that we virtually take a box of those eggs out. We pick one that will grow and mature, will be released and potentially turn into an embryo, implant and become a baby. And all the other eggs reabsorb into the ovaries. Those eggs that are in the ovaries are sort of a predetermined number since when the woman is in her mom's womb, and they are static, they don't move, they don't change much until puberty hits, and then the numbers will go down in time. And when we want to measure the egg reserve, what we want to do is know the size of that box, which is a proportion of how many eggs are left into the ovaries. And how many eggs do we have in the ovaries is something that is extremely variable. It starts with a birth around 1 million eggs, and then around the age of puberty, we've already lost a few eggs in the process. And then the best part of the fertility life is around 18 and 30 years old, when the size of the boxes that we're using is quite large, and also eggs age with us, and so the eggs are still relatively young. What affects how many eggs do we have? There are age-related circumstances with the number of eggs declining faster below above 35 years old, and even faster after 40 years old. There's a genetic predisposition. There are congenital conditions that one is born with that predispose to having less eggs. There's for example, predisposition. So if a woman has a mother or a sister that's gone through menopause early and so run out of eggs earlier than the 50 years old usual range, then there is a predisposition, and it may happen the same. There are lifestyle choices. For example, smoking can affect the egg count. There are medical conditions that go and damage the ovarian reserve, and so they destroy the eggs to a certain extent. For example, if there are cysts in the ovaries, endometriosis, if there has been a surgery and a part of the ovary has to be removed. There are some cancers that require chemotherapy, and the chemotherapy can destroy or affect the quantity of eggs that are still in the ovaries. And those are just some common examples of how the decline in number of eggs can become much faster. And so how do we know where we are in this graph. Of course, yes, age is a factor, but then since there are a series of other variables, then we want to know what is in a specific woman, the specific point in the graph where she is. And we can do it mainly through 3 different sort of tools. One is doing an ultrasound. It's called a pelvic ultrasound, so an ultrasound of the ovaries. And this ultrasound is aimed to count the follicles that we can see in the ovaries. The follicles are the containers of the eggs. So in the previous metaphor of the warehouse of eggs, they represent the size of the box. And we literally count how many eggs are used that specific month. There is a blood test that's called anti-Mullerian hormone that correlates to the number of eggs that are still in the ovaries. And then there is another hormone that's called a follicle stimulating hormone, which is an hormone produced by a gland in the brain that goes to the ovaries to convince the ovaries to release the eggs. And this hormone tends to go higher and higher, as if the brain was shouting at the ovaries to release the eggs. And this happens when there's less eggs. And so if that level is normal, it correlates with a normal number of follicles in the ovaries. If this number is very high, it correlates with a very low number of eggs in the ovaries. So why do we want to know this, and when is this relevant? Well, for natural conception, if you think about the fact that every month 1 egg is released and the rest is discarded, is quite irrelevant how many eggs we're discarding, as long as we are still releasing 1 egg every month. So if a woman has periods every month, she is releasing 1 egg. If she's trying to conceive naturally, then the wastage is irrelevant. If we are thinking about a fertility treatment, then what we want to achieve is collect and save as many eggs as possible. So make the most of what is in that box, because the ovaries have already pre-selected how many eggs they want to use that month, and we can't really manipulate that aspect. So if we want more eggs, we have to try to convince the ovaries in different occasions. We can't make the box bigger. So what do we do in those cases? What do we do with that information? Do we freeze eggs for everybody? Well, not necessarily. Not necessarily, because a lot of women will never need to use frozen eggs, will never need to have fertility treatment. 80% of the heterosexual couples that are trying to conceive naturally would conceive within a year of trying. And so that group of women would not require to use eggs in the future, so they may not need to freeze the eggs in the future. And so they may want to consider whether that is helpful or useful, or if they want to do it. But I would see it more as a sort of a backup plan or an insurance policy. So you may want to freeze your eggs because you never know what happens in your life, but then it's not necessarily something that you would use in the future. So who would benefit the most from the egg freezing? For example, someone that is young, say in their 20s or early 30s, but they are not ready to try to conceive, because eggs will decline in quantity and quality. And so if you're 30 and you are thinking about freezing your eggs, or you're not thinking about having a baby anytime soon, then you should think about whether you want to freeze your eggs so that in the future, if anything happens or if your fertility declines with age, you would have that backup plan ready to wait for you. It's very common that egg freezing can be offered to women that will have any kind of treatment that can impair their future fertility. For example, chemotherapy, radiotherapy, hormonal treatments, surgery that goes and affects the ovaries. And so in this field, I would consider also women that are actually transgender and transitioning to men, and they may not have the ovaries in the future because of surgical procedures that they would undergo in the gender transition. However, the eggs can be preserved and someone else can carry the pregnancy for them, for example. Another circumstance where it could be very useful to freeze the eggs is if someone is even trying naturally but has just started. It does not need fertility treatment per se, does not need to have IVF per se, but they may want to freeze some eggs when there's still some, so that in the future, say 1 or 2 years later, when they try to conceive naturally, if nothing happened, they would have some eggs that are in bigger numbers, and so they would be suitable and better placed to contribute to a pregnancy. Or in circumstances where we envisage that a fertility treatment may be needed. For example, a same-sex female couple, or in a case where there is endometriosis, where there is a problem with the tubes, where there is a known cause that would require fertility treatment in the future. Then if I am, say, 25 or 30 years old and I freeze my eggs now, when I would be 35 or 40 years old and I will have less eggs and lower quality eggs, I would have something that is in storage and would help me reach my dream of having a baby in the future. So what do we need to do to make the most of those boxes of eggs? We need to use some hormones that are the same hormones that the ovaries usually use to release one egg, but in higher doses, so that more eggs can develop. Then what we would do is we would try to understand how the ovaries are responding to the medications, and we do that through ultrasound scans, where we look at the ovaries, we count the follicles, we look at the follicles growing. So when the containers grow, it means that the eggs inside are developing. And then we proceed to the egg collection procedure, which is a procedure that is done under sedation usually, but it can be done awake. And it's an internal scan with a needle that goes through the vaginal wall into the ovaries and gets the eggs out. And once we have collected the egg, then we pass them on to the lab, and the lab will look after the eggs and prepare them. And I will then pass the stage to my colleague Rachel, who is one of our senior embryologists, and she will explain more about that part.
Hi everybody, thank you Agnese for a wonderful introduction and for building the picture and pointing towards the laboratory. So my name's Rachel Smith. I have a very fancy title, but I was an embryologist for very many years. So I am clinically based, but my role now is to look for innovation and technology that helps to improve your chance of success and also your journey with us, providing hopefully the team with more information about how we can assist you. So I'm going to give you a little bit of information about the process around egg freezing, and also some very unique and novel technology that we're using to learn more about eggs. So this is an overview of the process within the laboratory. Agnese has very succinctly told you about how we prepare you for an egg collection to maximise the number of eggs that we can collect. And our laboratory team are part of that process on your day of egg collection. We are in the laboratory waiting for follicular fluid, or the fluid to come from those follicles, for us to check for the presence or absence of an egg. So we do this with a microscope and a dish, and we check for an egg. And if we find an egg, then we would wash the egg and put it into an incubator during the process, and collate the number of eggs that we collect over the whole egg collection. Those eggs that we've collected need to then be assessed for their maturity, because it's important that they are mature, because the eggs that we freeze need to be mature. We then move towards the image capture of those eggs, which we are using some AI technology, a really unique system, to give us more information about the potential of your eggs and their future. Then after the images have been taken, the eggs will then be ready for freezing, which is done by our technicians through a sequence of steps prior to adding them into storage, where they will stay safely until you're ready to come back and use them when you're ready to start your family. So we'll look at these processes in a little bit more detail. So after you've finished in the theatre and had your egg collection, you would go back to your recovery room. And at this point, the doctor would come and speak to you about the number of eggs that we've collected. Now, at this point, the egg is surrounded by nursing cells or cumulus cells, which is like a fluffy cloud around the egg itself. Their purpose is there generally for fertilization to stimulate the sperm, but for freezing, we need to remove those cells to make sure that we can see the egg properly within and make judgments on whether to freeze it or not. And this process is called denuding, and these nursing cells will be removed from the egg so that we can see it in more detail. So when we've removed the nursing cells, we can see that there are 3 stages of maturity. And the maturity that we're looking for is the one with the tick. It's the egg with the small little addition, like a small tiny ball, which is called the polar body. This indicates that that egg is ready to receive a sperm. It's mature enough to be able to be fertilized in the future. The other 2 eggs, unfortunately, haven't matured enough for us to use them for you in your egg freeze cycle. But what we do know is that generally, because of our very experienced nursing and doctors team, the timing of your egg collection means that we maximize the number of mature eggs that we collect. And we get over 85% of the eggs that we collect are mature on average. Obviously, some people can get more, some people can get less. And it's these mature eggs that we freeze, so that when we come to thaw them, we will be able to inseminate them with ICSI, and they will be ready to have a sperm added to them. So when we're looking at the egg, once we have our mature eggs, the ones that we're intending to freeze, is there anything we can discern from the egg about its quality? Now, there is an understanding among embryologists that there isn't really a true grading system. The egg is either mature or it's not. And that's really the information that we can gather about the egg itself. We can see sometimes things that may be considered poor within an egg, but it's very hard to tell from a batch of good eggs what the distinguishing features are. So artificial intelligence has become a very big buzzword in our field, and it's become apparent that we can look at, say, images of either sperm, eggs and embryos and learn more than what we could perhaps perceive with the human eye about the potential of those gametes or those egg, sperm and embryos for the future. So with an egg, could we be able to see patterns or discrete markers that would be able to tell us whether that egg would become a blastocyst, which is the precursor of an embryo before we transfer it, or whether that egg would ultimately be able to get you pregnant and give you that baby at the end. So we liaised or collaborated with a company called Fertility, who are based in Canada. They've developed this AI technology, this novel system of looking at images of eggs to understand the patterns and markers in them that may be linked to potential outcomes. And these beautiful images of all the colours is how the AI perceives the egg once it's been analysed. So this technology is called Violet. It's a system where the embryology team take an image of each egg at the point of that denudation, that point where we're removing the cells from the egg. It's a process where it's done under a microscope. We can quickly take an image. That image is then uploaded to the cloud with just the image and your kind of hospital number and no identifying information. It quickly then generates a report which can then be used to support decision making in the future, and we can go through what that report holds in a few slides' time. So what the egg AI sees is this little graphic. We can see the original egg in the monochrome, and then you can see the AI's focus. So these are heat maps as well. So it tells us at what points in that egg is the AI specifically centered on and concentrated on. So we have this technology. Now, embryologists are generally very curious people. We like to challenge and ask questions. We are scientists, so we're expecting to challenge technologies that come our way to make sure that when we're introducing them, we're introducing something that will ultimately benefit yourselves. So we knew that Violet had been trained on a large number of eggs, so kind of equivalent to what an experienced embryologist would see perhaps in their lifetime of being an embryologist. But were they ultimately as good as an embryologist, if not better? So we did a head-to-head challenge. We took Violet to a competition. We had 300 eggs that we showed Violet, and then we showed these same 300 eggs images to 10 experienced senior embryologists. They had to look at the image and they had to decide, would that egg be a blastocyst or would that egg be fertilized? Now, as you can see from the scorecard, we didn't do so well. We had one embryologist that was able to beat Violet at predicting fertilization, but none of us embryologists were able to look at a single image of an egg and decide that that egg was going to become a blastocyst or not, any better than chance, like flipping a coin. But Violet was able to predict, seeing things in that egg that is beyond what the human eye can interpret, with 18% better prediction than an experienced embryologist could. So we considered this technology to be better than an experienced embryologist when reviewing eggs potential. So along with the AI probability of that egg, we also can provide more information based on personalized information from your treatment. So if you're looking at published data, there's lots of information that says the age you are and how many eggs it might take to achieve a live birth, a pregnancy, a baby. But as we know, even within a set of eggs, each egg could be different. And between patients, therefore, eggs can be different in terms of their potential. So can we give you a more kind of qualified success rate of your cycle when you come back to thaw your eggs in the future? So we use your age, the eggs that we've collected in terms of the numbers that we've frozen, the AI scores of your eggs, thaw rates that we know are well published in our literature on how eggs survive when we come to thaw them, and what live birth rates are like for each thawed event. So we can give you a tailored and specific understanding of your chance of success when you come back and use these eggs, helping you to make those really important decisions about when to start a family. So this is what the report looks like. you get a front page with all of your personalised predictions present. So you have the number of eggs that were frozen. You also have a understanding of how many blastocysts, these embryos that have developed the furthest, that we use for transfer and ultimately also to freeze them as embryos. So it gives you a prediction of how many you're likely to achieve, and also what your chance of having a live birth or even multiple live births would be, or babies, from that cohort, from that set of eggs that we've frozen. And this will be provided to you through our Salve app. So the report also includes an image of each of your eggs and the actual prediction of that egg to make a blastocyst. So it's a really exciting and novel piece of technology that we're using to give you far more information about the eggs we've frozen than otherwise you would have available. Prior to this technology, the only information the embryologist was able to provide you with was the number of mature oocytes that you had after your egg collection that we'd frozen. So this information helps to make it easier to make decisions for the future, because we're hopefully providing you with much more information and tools to help you to decide. So we're just going to look at the video from Future Fertility, which hopefully will give you much more insight into this wonderful, exciting technology.
Future Fertility has developed software tools powered by artificial intelligence that analyze images of each of your mature eggs non-invasively at the time of retrieval to provide you with a personalized assessment of your egg quality. Our AI model has undergone extensive training and testing using over 100,000 different egg images. Through this training, the machine learning model has learned patterns within these images that enable it to predict whether an egg will develop into a healthy embryo. By detecting intricate details of the egg that are invisible to the human eye, our model is able to more accurately predict egg outcomes, giving you an objective estimate of success. To assess your eggs, embryologists take images of your freshly retrieved, mature eggs within the fertility lab, then upload to our software for analysis and output a Violet report. Violet reports are tailored for egg freezing patients specifically. They provide you with images of each of your frozen eggs, predictions of each egg's probability of becoming a blastocyst, and offer an overall prediction of your chance of having a baby from the group of eggs that you've frozen. This prediction is based on your personalized egg assessment and statistical modeling.
So I hope you enjoyed that video. So we've been using the Violet software. As I say, we were very lucky to be part of that collaboration at the beginning. So we've been using this technology for quite a while now in all of our care clinics. It's included in the egg freeze packages that we have on offer, so there's no extra cost for this amazing technology. And in our own hands, we've been able to prove that it's better than an embryologist at being able to identify probabilities of success from just looking at the egg prior to freezing. So we have lots of data and information on the technology if you would like it sent to you. So in summary, the packages that we use to freeze Egg Safe and Egg Freeze AI uses this amazing Violet technology to provide you with much more information on your eggs, which would otherwise be unavailable to you. It's really quick and easy to perform in the lab. It's just an image on a microscope that we take during a procedure. And the report that you get obviously includes those images of the eggs that we've captured, giving you personalised information to help you make important decisions as you discuss your ongoing treatment or when you want to come back for treatment with your clinician, helping you to decide when's the best time, obviously, to start your family. So thank you very much. I think I'm handing back to you, Agnese.
Yes, and obviously, usually the cycle of the treatment goes through the consultation, the treatment, what happens in the lab, and then we usually then do a follow-up appointment when we discuss this very, very precious information. Now, research has told us that there is a certain number of eggs that gives a certain percentage of success when those eggs are then thawed and used. And this is based on age at freezing as a primary information, but it's not personalized. So before we do a treatment for the first consultation, we would use something like the graph that you can see in this slide, which comes from a lot of research that grouped information about a lot of eggs that were collected and frozen at different ages, and how those eggs have then resulted into a pregnancy, and how many eggs were needed in each individual circumstance. There is a correlation between the number of eggs and the chances of having a baby. This number has been set up in the region of 15 at 35 years old to get around the 70 to 80% chance of having a baby in the future. There's no specific number that will give 100% chance of having a baby in the future. However, knowing if your individual eggs, once they've been extracted and analyzed in the lab, have a better or a lower quality compared to your age range, can help understand if one treatment cycle, so going through the stimulation of the ovaries and the egg collection once, is sufficient, if you are satisfied with that potential, or whether you would rather try again so that you can have more eggs and a better chance that if you ever need to use those eggs, you would have a baby out of those eggs. And therefore, this is a very helpful tool to decide whether you stop there or whether you come back, and when you would come back for treatment. Within care, as Rachel has mentioned, we have packages, and initially you may be guided to think about whether you want to have one cycle of treatment or more than once, but then after you have the first cycle of treatment, you may want to revisit that information. And for younger women with a better potential, there are packages that cover up to 4 cycles of treatment at a fixed price, so that we can reach at least freezing 20 eggs. Or you can have the egg freezing protocol on individual cycles of treatment, which may be more suitable if you have a very good egg reserve, if you're young, and you probably are not expected to need more than one attempt of the treatment. Obviously, so far we've only covered the option of freezing eggs. When we talk about fertility preservation, we also can include freezing sperm and creating embryos and freezing embryos for future use, and we will leave those two for a different talk. But if you want to gather more information, our clinics are across UK and Ireland, the United States, and in Spain, and our lovely team from the new patient inquiry team would be able to guide you through this process and give you more information about the options that you have for treatment, the costing, very detailed information of what we can offer as a clinic. And CARE does have a resource hub on our website. We have Care Pals, which are dedicated support admin staff that would follow you through your treatment. We do have a forum. We have counseling available throughout the process. We are present on social media, and we recently also introduced a personalized app that would help you with reminders of your medications, keep track of your appointments, and access our team more easily, sign your consent forms, pay your invoices, and there's a lot of resources that come with each step of the treatment so that you can get guidance at any point of the process. And here I came to the end of our presentation, and please feel free to ask questions.
I think some have been posted, Agnese, so do you want me to read them? There's one asking about when they're ready to use the eggs to create an embryo, what does that process look like? So I'm happy to talk about the lab side if you want to talk about how the first part of that process would start.
Of course. So when someone is ready to use those eggs, it would be in different circumstances. It could be that, for example, this lady is in a relationship, she's tried to conceive naturally for a while, or she has not found Mr. Right, or she is in a situation where she would actually would like to conceive with the help of a surrogate, for example. There's such a variety of circumstances. So the process at that point, from the medical point of view, would go through a consultation where we would assess what your individual circumstances are. And then at that point, if the process involves going through a fertility treatment to use those eggs, we would use normally tablets and suppositories that prepare the womb. The lab will prepare the embryos, and we would put the embryos into the womb.
Okay, and for the lab, in terms of that process, obviously an egg thaw is timetabled to coincide with a sperm sample for us to be able to inseminate the eggs. And as Agnese has already spoken about, that can be your partner's sample or it can be a donor sample. We then would inseminate the egg using a technique called ICSI, which is where we inject the sperm directly into the egg. Then the egg would be assessed for fertilization to see if it's become a fertilized embryo, which would then be cultured for at least sort of 5 days for us to make a decision on which embryo would be the best one to transfer and which embryos would be suitable for freezing. And we would give you information all the way through that process at different points, so we keep you updated with how every step is being managed and how successful it is, all the way up to the transfer that Agnese mentioned, in where the doctor would replace the best embryo back into your womb.
Yes, so we have another question. Would this procedure damage my egg reserve, and then I won't have enough eggs to get pregnant naturally? Well, the answer is absolutely no, because every single month, if we think about the initial analogy of the warehouse, we take one box of the eggs out of the warehouse, and we use one egg, we discard all the rest. What IVF does is still uses the same box and makes the most of the eggs that we would have discarded. So it's actually optimizing what your body had selected for that month, but in no way it affects the other eggs. So the rest of the eggs will stay into the ovaries, and going through fertility treatment, even repeatedly, will not affect your future ability to fall pregnant naturally. The only caveat in this circumstance is that every time you do an egg collection procedure, there are some small risks. For example, there is a minimal risk of infection, and the more you repeat one procedure, the more this risk can accumulate, and so it becomes a little bit higher. So when you go in the region of 6, 7, 8 egg collection procedures, that's where there is a slightly higher risk of infection, for example, and then some precautions have to be taken to mitigate that risk. But the egg collection procedures themselves do not affect the egg reserve. The stimulation of the ovaries does not affect the egg reserve.
I think there's more questions for you, Agnese. I'm afraid you're not off the hook.
So we are trying to get pregnant with my wife having endometriosis stage 4. We were offered a laparoscopic surgery in near future. In this context, we have some questions. Would you recommend egg freezing prior to surgery when one side tube is inflamed? How long is the process from evaluating number of eggs with ultrasound till the completion of freezing? And is there a risk of over-releasing the eggs and completely depleting the egg reserve? One ovary is healthy, would it be affected? So I'll start from the last question, and the same answer to the previous question applies. So the egg reserve is not depleted if you do a stimulation of the ovaries. Endometriosis is a very complex condition, and it can affect fertility and the ovaries in different ways. But the general principle is that if there is a cyst or any kind of lesion inside the ovary, and you are trying to remove this lesion, with the affected part of the ovary, you will take away some of the good eggs. Therefore, it's always a little bit difficult to find a balance between doing an egg freezing procedure before the endometriosis surgery or leaving this for after, because the downside of stimulating the ovaries when the endometriosis is still in the ovaries, for example, if there is a big cyst, is that when you're trying to get the eggs from the ovaries, you've got the cysts that can obstruct the passage. It can make it more difficult to get to the eggs. And also endometriosis predisposes to infection when you have the egg collection procedure. Therefore, it's all about, in the individual case, so in your wife's case, looking at the ultrasound scan, looking at the previous history, if other surgeries have been done, what kind of inflammation there is in the tube, if there are other conditions, if the ovaries are easy to reach, or if endometriosis has caused the ovaries to move away and be difficult to get to and get the eggs out. Therefore, there can't be a very straight answer to this question, but it has to be tailored to your specific circumstances, and you would need a consultation to give an answer that is tailored to your circumstances. In terms of the timing, usually between the moment where the first consultation is done and when the egg collection happens, there can be a variable time. There can be as short as around 3 weeks, as long as around 3 months, because there's different ways of stimulating the ovaries that can take a different amount of time. And sometimes for the endometriosis, there is a preparation of the ovaries to try and shut down the endometriosis and make it shrink a bit. That can require 1 or 2 months or up to 3 months before the eggs can be then taken out of the ovaries. So again, it's something that needs to be tailored and agreed based on specific circumstances.
Okay. I think there's one question come in as well, Agnese. I'm happy to do my side and then you can do yours.
Yes.
So Once the egg has been artificially inseminated and replaced into the womb, is there a chance that the body can reject this and result in miscarriage? Well, from an embryology point of view, once we've created an embryo, even though we have an embryo that's divided in culture to a stage of development where we'd be happy to replace it because it's a blastocyst and it has a good chance of success, we're only looking generally at the embryo in terms of its appearance and how it's moved through all the stages of development. We cannot see if that embryo is chromosomally normal, and miscarriage is generally increased or happens because an embryo is not normal chromosomally. So this is one of the biggest reasons why miscarriage can happen. So there is techniques that we can do to identify an embryo, to understand its chromosomal makeup, to identify whether it's normal or abnormal, which is called PGT-A. So that could be discussed if we felt that that is a risk. Obviously, you can't exclude it from any age group, but the chance of you having an abnormal embryo also increases with age. But the point of egg freezing is also to stop the clock on those eggs. So once you've frozen them, obviously we apply the age that you were when you froze the eggs, making those decisions, and not the age that you are when you come back to have them replaced. So generally in IVF, the miscarriage rate is around 20%, but that can be reduced, as I say, by offering some genetic testing on those embryos prior to transferring them, if that's something that you're very concerned about. So that's the lab side. I'm sure Agnese can talk about some of the other risk factors associated with increased miscarriage.
Yes, so as Rachel said, the key aspect is that age is a predisposing factor for abnormalities in the embryo. So chromosomal abnormalities, wrong number of chromosomes, and that is the main cause of miscarriage. It is lower when you are in your 20s, that increases in your 30s, and is much higher in your 40s. And so the risk of miscarriage is higher, related to age of the eggs. There is a minimal factor that is also related to the male age. So there is a recent study that showed that actually, even if women have the same age, if the partner is older, the risk of miscarriage is a little bit higher. So that could also be a contributing factor. And again, it's thought to be related to the number of chromosomes in the embryos. And another aspect is that in a very small minority of women, there can be some autoimmune conditions, some medical conditions that increase the risk of miscarriage. That is sort of a very, very subspecialistic area of the fertility and obstetrics, which relates to what are called the recurrent miscarriages. And in those rare cases, there are some medications that can be taken to reduce the risk of miscarriage, but that is not any higher than the risk of miscarriage with natural conception, because it's related to underlying health conditions. And even with IVF, the risk of miscarriage, if the embryos are not tested, is the same as natural conception. And the percentage mostly varies with age. Below 30 years old is probably in the region of 10 to 20%. Between 30 and 40 years old, we're probably closer to 25, 30%. And above 40, it can reach 50 or 60% of the pregnancies. And another aspect that goes with age is, for example, the risk of some chromosomal abnormalities like Down syndrome. which is around 1 in 1200 around 30 years old, and it becomes 1 in 100 around 40 years old.
I think we've exhausted the questions unless there's anything else that people want to ask while they have us.
We have another question. I'm concerned about the toll the hormone injections will take on my body, for example, weight gain and other longer lasting effects. So there are some risks related to the ovaries responding a little bit too much to the medications, but usually the treatment is tailored to the specific needs. So if your egg reserve is higher, you will take less medications. If your egg reserve is lower, you will take more medications. But the side effects of the medications, which can be quite variable, are mostly related to the specific time whilst the medications are taken, and they are reversible. So during the stimulation, you may have, for example, bloatedness, feel a bit uncomfortable. Some women experience, for example, headaches, or they can have sometimes hot flushes, vaginal dryness, depending on the medications that are used. But as soon as those medications are stopped, which is usually within a couple of weeks, those symptoms go back to normal within a couple of days.
Okay, is there any more questions? I think somebody's responding to one of the queries from the team.
Yes. Yes. I don't think we have any more sort of clinical questions. If we don't have any more questions, then we thank you for attending this webinar. We hope it's been helpful, and please do not hesitate to contact the clinic if you have any specific queries. And in the chat box, there's a reference of our inquiries team phone number and email if you want to get in touch.